Hello everyone, hope you're all doing good. In this video, we are going to discuss about operative vaginal delivery. See, what is operative vaginal delivery? This is a method of vaginal delivery using vacuum or ventouse or forceps. In this, we are going to expedite the delivery of the baby due to various reasons. But it will be simulating a natural vaginal birth, right? So, let's go on to the topic. Operative vaginal delivery. So, this can be an emergency or elective type of assisted delivery. We'll be using vacuum or ventouse or forceps. Okay, that is obstetric forceps. The goals of doing operative vaginal delivery include: number 1, it will mimic spontaneous vaginal delivery. We can expedite the delivery when there is maternal or fetal morbidity expected. Clear? Right. Now we'll see what are the indications of operative vaginal delivery. Indications of operative vaginal delivery can be put as maternal causes and fetal causes. We'll see the fetal causes first, and they include malposition with relative dystocia. For example, when there is a occipito-posterior position or a occipito-transverse position, right? Then there is a suspected or anticipated fetal compromise. And the maternal causes include the conditions in which there is a need to shorten the delivery interval. Okay, so these may include maternal cardiac condition when she falls under NIHA 3 or NIHA 4, when there is a hypertensive crisis or myasthenia gravis, spinal cord injuries. In spinal cord injuries, there is a risk of autonomic dysreflexia. Okay, this makes natural delivery complicated. Then, in case of proliferative retinopathy as well, when there is inadequate labor progression, or when there is maternal fatigue or exhaustion. Clear? Okay. So, these are some of the indications of operative vaginal delivery. Now, we'll see some of the requisites, that is the repeating. Now, we'll see some of the prerequisites of operative vaginal delivery that is given by RCOG. So, RCOG, that is Royal College of Obstetricians and Gynecologists UK, has given some prerequisites for operative vaginal delivery. Clear? So, let us see. We have to do a full abdominal and vaginal examination first. Okay? Vaginal examination first. In that, the following criteria should be satisfied. So, the criteria include: number 1, head is less than or equal to 1/5 palpable per abdomen. Second one, the fetus should be in a vertex presentation. Number 3, cervix is to be fully dilated and rupture of membranes has to be occurred. Okay. Then you have to check the exact position of the fetal head by vaginal examination so that proper placement of the instrument can be done. You have to assess for the caput as well as molding in the fetal head, and you have to check whether the pelvis is adequate or not. Okay. Suppose if it is not adequate and there is irreducible caput, then there is no meaning in performing operative vaginal delivery. Clear? So, these are the criteria. So, the head should be less than 1/5 palpable per abdomen. That means the head has descended down and it has come to the lowest fetal station, right? Then the baby should be in the vertex presentation, the cervix should be fully dilated, the membrane should have been already ruptured. And then exact position of the fetal head for the fetal positioning, whether it is in the occipito anterior, posterior or transverse position should be done. We have to check for the caput as well as molding, and finally don't ever forget to check about the pelvic adequacy as well. Clear? Right. Now, it's still not over. We have to do preparation of the mother as well. So, for preparation of mother, you have to give her clear explanation of the procedure you are planning, and an informed consent should be obtained. There can be need of appropriate analgesia. Usually a regional block or even a pudendal block can be preferred. Maternal bladder should be emptied, and if needed, an indwelling catheter can be kept in place. And all these procedures should be carried out under aseptic technique. Clear? Right. Now, it is not only necessary that we have to prepare the mother, we have to prepare the staffs around also in case of operative vaginal delivery. Okay, so we will see what we have to do. So, preparation of staff. Now, the obstetrician who is going to perform the procedure should have an adequacy. Repeating. The obstetrician who is going to perform the procedure should have an adequacy of skill. Okay. So, there should be adequacy of knowledge, skill, and there should be some experience as well, and there should be adequate facilities available. Adequate facilities means adequate bed, adequate lighting, etc. And always remember to have a backup plan if suppose the operative vaginal delivery is going to fail. That is, you have to alert the theatre staffs to keep ready of the theatre for cesarean section as well, right? And a senior obstetrician should be present if this is being performed by a junior obstetrician. And anticipation of complications anytime is necessary. For example, anticipation of shoulder dystocia or postpartum hemorrhage as well. Then personnel that is trained in neonatal resuscitation should also be available by side. Clear? Yes. Now, these are all the ICOG criteria. Okay, how you are doing a full abdominal and vaginal examination, how you are preparing the mother, how you are preparing the staff, etc. Right? Now, we will go and discuss in detail about the obstetric forceps delivery alone first. Right? So, obstetric forceps delivery. See, obstetric forceps is an instrument that will be applied to the fetal head, and when you are giving traction over the instrument, the fetal head will be following the traction and coming out, right? So, instrument that is to aid in delivery of the fetus by applying traction over fetal head. Right? See, there has been modifications of more than nearly 700 different types of forceps over there till now. Okay. So, before going into the types of forceps, we'll discuss about the parts of forceps. So, parts of forceps, there are 4 major components in a forceps. Okay. So, these are the 4 major parts. We have the blades. Okay. The blades are further divided according to the side that is going to come in contact as cephalic curve, which is going to accommodate the fetal head, and the pelvic curve, which is going to be in touch with the maternal pelvis, and you have the shanks, handle, and other than that you have something called as lock as well. Clear? So, the blades, shanks, lock and handle are the 4 major components in forceps. Clear? We will see one by one. If you see the blades, as I have told you, you have a cephalic curve or a pelvic curve. Repeating. When you see the blades, you have 2 sides, right? You have a cephalic curve that is accommodating the fetal head, and there is a pelvic curve as well that is going to be fit into the maternal pelvis. And the shape of the blades can be oval or elliptical, as well as the blades can be solid or fenestrated as well. Clear? Right. And the second part is the shanks. Okay. If you see the shanks are connecting the blades to the handles, right? So, shanks are the parts that is connecting the blades to the handles. Okay. Shanks can be parallel or crossing over, right? The third part is the lock, which is the articulation between the shanks. Okay. There are different types of locks, like you can have an English lock or sliding lock, etc. Okay. And the fourth one is the handle. So, handle is where the operator is going to hold the forceps device. Okay. So, with the handle, the operator holds the device and traction is applied. Clear? Right. Now, if you generally see, the length of the obstetric forceps is around 37 centimeter, and the distance between the tips of the forceps is going to be 2.5 centimeter when it is locked, and actually the widest diameter between the blades is going to be around 9 centimeters. Is that clear? Yes. Now let us discuss about some of the important types of forceps. Okay. So this forceps is known as Wrigley forceps. Okay. So this is a Wrigley forceps. This forceps is an outlet forceps that is short, okay, and it is of lightweight as well. The total length of the forceps is 27.5 centimeters and the shanks are around 2.5 centimeters. Clear? This is the Simpson forceps. Okay, so this is somewhat lengther than that, right? And you have fenestrated blades, okay, that are curved towards each other. Okay, so this side appears to be almost straight, whereas this side appears to be curved. Okay, and you have an English lock over here. Okay, So this is the commonly used forceps for outlet delivery. It has an elongated cephalic curve and these can be used when there is substantial molding of fetal head. Okay. And the next type of forceps is keylant forceps. Okay. Here you have a sliding lock. Okay. So that is the difference. And it also has a small pelvic curve. Okay. The pelvic curve is very small. So features include it has a small pelvic curve and it has a sliding lock. It is suitable for fetal head with little molding. And this is most commonly used for rotational delivery and it also helps in correcting the asymptotism. Clear? Right. And this is another important type of forceps which is Piper's forceps. So this has a distinct perineal curve as well. Okay. So this has a distinct perineal curve as well. And this is mostly used to deliver the after coming head in breech. Clear? Yes. The next one is Tucker-McLean forceps. Okay. And this is also used in rotational delivery and it is suitable for fetal head with little molding. Okay. So, and the last type of forceps is Bratton forceps. Okay. So, this is a rotational forceps again and it is useful in delivering the babies in occipito-transverse positions, especially in a platypaloid pelvis. Clear? So, these are some of the forceps types that are important, right? Now, we will see the ACOG classification of forceps delivery. So, ACOG classifies forceps delivery into three main types. Okay. So, first one is outlet forceps. So, outlet forceps criteria include the scalp is visible at the introitus without separating the labia. Okay. Without separating the labia. Number 2, the fetal skull has reached the pelvic floor. Number 3, the sagittal suture is in the anteroposterior diameter or right or left occipito-anterior position or even occipito-posterior position as well. Okay. And remember one important point that fetal head is at or on the perineum and rotation does not exceed 45 degrees. Clear? Yes. And the next one is mid-forceps. For mid-forceps delivery, the station of the fetal head should be more than plus 2 centimeter. Repeating. For mid-forceps delivery, the station of the fetal head should be more than plus 2 station, but the head should be engaged. Okay. Usually at this stage, it is rarely attempted. Okay. And it is when it is attempted, it is associated with increased risk of morbidity also. Better to proceed with cesarean section if there is a need of application of mid forceps. Third type is high forceps delivery. Actually, this is not included in the classification. Okay, and it is not recommended as well. Clear? Next we will see how we are going to apply forceps. Okay, so for application of forceps, what you have to do is, when you are going to apply the left blade of the forceps, you have two blades, right? One is the right side blade and one is the left side blade. So what you are going to do when you are going to apply the left side blade means, you have to leave your right hand like this, okay, in between the maternal pelvis and the fetal head, and you have to make space for the left blade, okay. Then you have to insert your left blade with your left hand, okay, and you have to catch hold it, the fetal head with the curve, okay, with the cephalic curve. And the same procedure should be done on the right side also. So you will be making space with the right hand, then holding the right side blade in your right hand, you have to slowly introduce it along the hand, okay. So this is how you apply. So that's what they have done here, okay. So they have applied one blade first, followed by two blades, and then after applying, you should properly interlock the both the blades, okay. So after application, if you see, the biparietal diameter corresponds to the greatest distance between the two blades, okay. So after application, you have to decide your direction of pull, right. So direction of pull in case of outlet forceps, you have to give two pulls only. First you will give a downward pull, then it will be followed by a downward and forward pull. Clear? Whereas in case of low forceps, you have to give three pulls, okay. First pull will be downward and backward. Second pull will be downward, and third pull will be downward and forward again. Clear? So these are the different type. So this is how you will be delivering the fetal head, right? And the maximum traction force that is applied in the case of primigravida is around 16 to 18 kilograms, and in case of multigravida, you have to give a traction force around 12 to 13 kilograms. Clear? See, applying forceps has great advantages, okay. So we have seen there is rotational forceps also. So if the head is not rotated, it can help in rotation, and you can even deliver various positions of fetal head like occipito anterior or occipito posterior. Face presentation can be delivered with forceps, okay. Only position where you shouldn't apply forceps is the mento posterior position, because we know in mento posterior position vaginal delivery itself is not possible, right. We will be planning only for cesarean section, so will not be permitting forceps delivery in case of mento posterior position. Clear? However, any instrument that is applied on the human body has some disadvantages, right. So we have some of the maternal morbidity conditions also that can be associated with forceps delivery. If there is greater rotation, that will result in increased degree of perineal laceration as well as increased blood loss. There can be postpartum urinary retention and bladder dysfunction. There can be anal sphincter dysfunction as well. Infection, pelvic hematoma, and there can be chances of traumatic postpartum hemorrhage that can even result in maternal shock. Clear? And what are the fetal morbidity conditions we can expect? There can be cephalohematoma, skull fracture, intracranial hemorrhage, brain damage as well. There can be marked depression of respiration and that can even result in hypoxia, facial palsy, brachial plexus palsy can also be expected, and there can be soft tissue injury including the face, that is there can be bruising or laceration, and cord compressions can also be there. Okay. So, these are some of the fetal morbidity conditions, right. But there are certain conditions where you have to apply prophylactic forceps, okay, only to shorten the second stage of labor when the maternal or fetal complications are anticipated. Okay. So, these conditions may include eclampsia, maternal heart disease, previous history of cesarean section, low birth weight baby, and patient is under epidural analgesia. Okay. So, when you consider the forceps delivery has failed, so failed forceps delivery will be when the fetal head does not advance with each pull, then fetus is undelivered after 3 pulls with no descent even after 30 minutes. And forceps fails means what do you have to do? You have to go for a cesarean section. Is that clear? Right. Now, we will start with vacuum extraction or venous delivery. Vacuum extraction or venous. See, this is an instrument that is designed to create a vacuum. Okay. So, vacuum is created between the instrument and the fetal head. Okay. So, generally vacuum extractor consists of a vacuum cup that is of the diameter 3, 4, 5 or 6 centimeter, etc. So, if you see this pic, you will be able to understand the parts well. So, this is the cup. Okay. So, this cup can be made up of metal or silicone as well. Okay. And this is connected to a rubber tube and this will be connected to a glass tube as well. Okay. So, this is where we are going to release the negative pressure. Okay. So, this is a manometer to declare the negative pressure and you have a hand pump as well. Okay. So, this is a manual pump for creating a negative pressure. Clear? Right. So, as I have already told you, you have two types of cups in a vacuum extractor. One can be metal cup and another can be soft cup. So, vacuum extractors are also two types, metal cup vacuum extractors and soft cup vacuum extractors. Clear? Right. Now, we will see the difference between the metal cup and the soft cup vacuum extractors. So, first is synthetic cup, that is the soft or rigid cup, and another one is metal cups. Okay. So, the rigid cups consist of handheld, disposable, rigid cup or kiwi omni cup or conventional celastic cup device. Okay, and this has a higher failure rates, but they have less chance of neonatal injuries. Okay, so this can be used in straightforward deliveries. For example, when there is no need of any rotation or capute. Clear? Whereas metal cups are used for the delivery of occipito posterior, transverse or difficult occipito anterior positions. Clear? Now, we will see what are the indications of vacuum extraction. So, indications of vacuum extraction. Usually, vacuum extraction is not preferred in preterm babies, especially less than 34 weeks. Okay, so it is generally reserved for babies who are more than 34 weeks of gestational age. Okay, otherwise the requisites and what are the indications are similar as that for the forceps delivery, right? We have some contraindications for applying vacuum. Contraindications include when there is operator inexperience or inability to assess fetal station, when there is high station that is more than 0 level, or when there is suspicion of cephalopelvic disproportion, other presentations are there, that is other than vertex, any other presentation is there. Then as I said, premature fetus, less than 34 weeks also you are not going to do, and when there are intact membranes also forceps should not be applied. Clear? Right. Now we will see what are the prerequisites of the procedure. So, anytime you are going to explain the procedure to the patient and get the consent as well. Patient should be placed in a lithotomy position, bladder should be emptied and antiseptic measures should be carried out. Okay, that is cleaning up of the vagina, perineum, everything should be done. And finally, you have to do a pelvic examination as well to assess the pelvic capacity, fetal station, cervix dilatation, degree of flexion of head, as well as we have to assess the membranes as well, whether it is ruptured or not ruptured, right? Now we have to know at which point this ventouse should be applied. So there is one specific point here, that is application of the cup should be done at a point called flexion point, and remember the flexion point is just 3 centimeter before the posterior fontanelle. Okay, remember it is not the anterior fontanelle, 3 centimeter below the posterior fontanelle. In some textbooks they have given that the space between the anterior fontanelle and posterior fontanelle will be divided into 3 centimeters. Okay, so 3 centimeters, so the distance will be around 9 centimeters and you have to apply it in the last third. Okay, right. So now what is the importance of this flexion point? Flexion point is helpful in promoting the flexion, descent, as well as it also helps in some degree of auto rotation as well. Clear? If you are giving traction at this point, the fetal head will be flexed toward the smallest diameter, that is suboccipito bregmatic diameter, which is around 9.5 centimeter. Clear? Yes. There should always be a precautious measure also while you are applying the vacuum cup. So, there should be no cervical or vaginal tissues or the umbilical cord or even a limb in case of compound presentation, that is included in the cup. Okay, you have to just check this before giving the traction or creating the negative pressure. Clear? Right. Now, how we are going to create the negative pressure? So, creation of negative pressure. See, while you are using rigid cups, the negative pressure is gradually increased from 0.2 kilogram per centimeter square. Every 2 minutes, you can increase 0.2 kilogram per centimeter square up to 0.8 kilogram per centimeter square is attained. Clear? So, what will happen is, with this pressure, there will be creation of a artificial caput within the cup. Clear? And then, with soft cups, the negative pressure can be increased up to 0.8 kilogram per centimeter square even within 1 minute. Okay, so that is the advantage of the soft cups again. Clear? And while giving traction, you have to remember the traction should be given intermittently and it should be coordinated with maternal expulsive efforts as well as her uterine contractions, and then traction should be applied in the line of pelvis, pelvic axis, and it should be particular to the plane of cup. Clear? The scalp is sucked into the cup and an artificial caput succedaneum or chignon is produced while using a vacuum delivery. Okay, but this will usually disappear within few hours. Okay, so we have to know if there is a need for reapplication of cup. Okay, so if there is a cup detachment for the first time, okay, you can reassess and apply the cup. Okay, but if there is a detachment for the second time even, better to go for cesarean section than to trying reattempt. Okay, reattempt can be tried only when the other conditions are so much favorable. Okay, and remember, cesarean section is necessary when there is inadequate descent or rotation as well. Okay. Now, so when we can say that vacuum has failed? So, failure of vacuum is there when fetal head does not advance with each pull, fetus is undelivered after 3 pulls with no descent or even after 30 minutes. Then cup slips off the head twice at the proper direction of pull. Okay, when we are giving proper direction itself, there was 2 slips. Okay, with maximum negative pressure. Clear? Now, what are the complications that we can expect with vacuum delivery? We have maternal complications like there can be perineal, vaginal, labial, periurethral or cervical lacerations. Then annular detachment of cervix can happen if it is applied to an incompletely dilated cervix, right? And there can be chances of cervical incompetence in the future pregnancies as well as prolapse also. Yes. Now, what are the fetal complications expected? Fetal complications include formation of Kephel hematoma or scalp lacerations and bruising. There can be subgaleal hematomas, intracranial hemorrhage, neonatal jaundice, subconjunctival hemorrhage. There can be injury to 6th or 7th cranial nerves as well. And finally, retinal hemorrhage and fetal death can also be anticipated. Clear? Right. Now, let's do a comparison between forceps and vacuum delivery. So, forceps delivery and vacuum delivery. First, we'll see the points about forceps delivery. Then, we'll try to bring out the points about vacuum. Okay. So, forceps delivery is less likely to result in neonatal morbidity. Okay. Second one, but there is more chance of maternal injury. Forceps delivery results in successful vaginal delivery over a short period of time. And it is even suitable for preterm babies as well, less than 36 plus gestational age. Okay, and it can also be applied in case of other presentations as well, like face presentation or breech presentation. There is less chance of Kephel hematoma. The failure is less and maternal effort is not needed in case of forceps. Okay. Whereas in vacuum, there is an increased incidence of fetal morbidities like Kephel hematoma or subgaleal hemorrhage or retinal hemorrhage as we have discussed. Then, and when you apply vacuum, it doesn't mean that it always ends up in a successful vaginal delivery. So, there is a less chance of vaginal delivery and there is less use of regional anesthesia. Okay, for forceps you need regional anesthesia or pudendal block, but for vacuum it is not like this. Okay, and the maternal injuries are less serious and pain is also less with vacuum forceps for the mother. And one advantage is it promotes the auto rotation of the fetal head and less traction is needed in case of vacuum delivery. Clear? So, I hope you would have understood, and with this we are completing the discussion about operative vaginal delivery. Repeating. So, hope you understood this topic well, and with this we are completing this discussion about operative vaginal delivery. Until we meet in the next video, take care, happy learning, and bye bye.